Thank you, Chairman. General Horoho, yesterday we had in the Defense Committee and last week in the Armed Services Committee, Secretary McHugh and General Odinero both said that when a service person, at least this may have just been Army, and which may be the next question I would ask, is this service-wide? When they transfer from one base to another, their health records are generally available, but their mental health records are not available to anyone in the command structure. So if you are having mental health treatment and you transfer to another base and choose not to have mental health treatment, no one really understands, in the command structure at least, that disruption. Is that your impression as well?
Senator, if I can expand upon that, so there's several things. Right now, if a soldier is screened as high risk and is receiving behavioral health treatment and gets put on medication, there is a code that's put in a system, e-profile, that keeps them from being able to PCS to another station until they are at a stable point. When that individual is then able to move to another place, there is a behavioral health provider warm handoff, so for continuity of care that they continue. So the losing behavioral health physician calls the behavioral health physician at the gaining. If it is a high-risk soldier on stable medications, then there is a notification to the command surgeon and then also from commander to commander. So we have different levels that we do that. If it is someone that is a low risk, their medical records transfer in the information, but the commander is not called for those that are in a low risk. So we have it almost stratified depending on the types of behavioral health and the status of where they're at.
Is that the same service-wide? Is that the same, Admiral, in the Navy and in the Air Force, General?
Yes, sir, it's very similar. I think the challenge is that, again, anybody who has fairly debilitating or remarkable issues with mental health are well demarcated, and a warm handoff is made if they are allowed to transfer. The challenge comes in those who are deemed to be mission ready or who are not deemed to be unfit for service. And when they challenge from one base to another and they've been followed for a fairly routine mental health disorder, the current commander, and I think this is what the Army Chief of Staff was referring to, the current commander will not necessarily know their mental history because it's not considered to impact their ability to perform the mission. The commander can only have insight into a soldier or sailor's or airman's condition if they are deemed unfit to perform the mission, and then they are entitled to know what is going on with that person. Otherwise, it has to be voluntarily given to them.
And General Travis, is that the same?
It's the same, sir.
And so in this case, with the exception of someone who is deemed to be, I believe the term you used was at risk, or is the health record treated the same way as the mental health record? So the commander also wouldn't see the other health record under any circumstances unless there was something in that health record that indicated that individual was not ready for certain kinds of duty?
Sir, the time that a commander gets to know is...
I don't think your mic is...
Sorry, Senator. The time when a commander gets to know is if there is something that they believe is at risk, will impact the mission. If there's a concern, then the provider, whether it's a behavioral health or a general physician, will give that information to the commander for them to know.
And the behavioral health is treated the same way as physical. The physical health concern would have the same...
Yes, sir.
The same treatment. Well, treating these in the same way, and do you all think that, anybody think that current system creates a gap that's problematic? No?
Sir, the only comment I would make is we wrestle with how much to share with commands because the individual service member may not come forward for routine or for otherwise troublesome symptoms or issues if they believe everything they're going to tell somebody is going to be given to their commander or given to other people. So we have commanders who sometimes say, please tell me every individual who's in my command who's being followed for mental health issues, simple or severe? And the answer is that may help in some cases, but we worry about the individuals who won't step forward then and say, I have a problem, if I know my commander is going to know about it right away.
You know, the National Institute of Health says that 1 out of 4 adult Americans has a diagnosable mental health challenge and treatable. Any reason to believe that that number is significantly different than that in the military, General?
I don't believe it's different because we recruit from the United States. And if I could just add one thing on the security clearance is a good example. Back in 2007, there was tremendous concern in the security clearance when you had to notify and state that you were getting behavioral health treatment. And so many soldiers would not get treatment based on that because they didn't want their career to be ruined. When that was taken out as a question, if it was behavioral health related to some type of trauma or deployment, they did not have to answer yes to that question. That helped to actually increase soldiers feeling comfortable seeking behavioral health care.
Well, I think that's probably right. I think, read may have been sort of an in-depth news article lately on veteran suicides, that many of those veterans had been in a combat situation and many had not. And, you know, I don't think, we don't want to just assume that somebody who had some multiple deployments or post-traumatic stress syndrome from having been in a different combat environment than soldiers and airmen, Marines, sailors used to be in. We don't want to assume that they're the only ones that are likely to have a problem on separation from the military. I mean, there are so many ways to deal with these problems, and back to the chairman's view of what we need to do to be sure that we're helping you get the professionals you need in the health service that can be there to deal with a problem that is societally we need to deal with in a better way, and in the military I think we need to deal with in a better way as well. Chairman, I have another question, but I'll ask it if there's after you all have had a chance for a second round. General Rojo, I want to talk about military hospitals a little bit. I understand that the command is, at least the Army command, is in the process of completing a study that will assess all its Army hospitals across the country. And when will that study be available?
Senator, there's a couple things. Over the last 2 years, we have been looking across all of our military treatment facilities to see where we can recapture care within the civilian network to bring more care back into our facilities. Where do we need to maybe reshape some of the capabilities, and then how do we standardize the care at our clinics, our community hospitals, and our medical centers? So that has been ongoing over the last 2 years, and we're making some changes there. We've also been part of the OSD study, the modernization study, where Army, Navy, and Air Force has been evaluated on efficiencies across all of our platforms. And then part of what we've got to do too is marry up our decisions with the final end state for our Army. So as the Army reduces down to 450K right now, then that is driving some decisions of how much capability we can have at a certain installation based on the reduction of the population. And so there's not a certain line in the sand with the time. It's been ongoing, and we know some of our areas where we're already starting to look and say we maybe need to move some of our capabilities because we have the recapture. And then there's some areas where we're saying we need to move some of our personnel because it would be better if we bought the capabilities within the civilian sector.
So like at the General Leonard Wood Army Hospital at Fort Leonard Wood, Missouri, at least that was ranked the Army's #2 overall MILCON construction project in 2010. The only thing that's really changed at that 1941 facility since 2010 is the maintenance goes up every year, and I think it's moved outside the 4-year window now. What would be the reason for that?
Sir, Leonard Wood remains our #1, actually, for for a new facility. But right now, as we stood up the Defense Health Agency, military construction and health facility planning is no longer an individual service. It actually is now within the Defense Health Agency. So each of the services puts in their request, their priority list, and then that decision is actually made by OSD.
So the hospital at Fort Leonard Wood is still the Army's #1 priority for hospital construction?
Yes, sir.
And that all goes to who now?
So that goes up to the Department of Defense for the decision to be made on military construction and funding. And part of what we've asked Fort Leonard Wood to do is to really, they have developed a get well plan to actually look at how do they bring more patients into the current facility that they have, so that they build up their patient population. And we've worked very aggressively with the command on the ground in that area.
Do any of these Army facilities also, are they available to the community or only to retirees, veterans in the community? How does that work?
Right now, the rules of engagement, it's for active duty military, their families, retirees, and their families.
And there are some communities where you would decide the better way to do that might be to take care of that in the community hospital and pay for that rather than have a hospital? Is that what you said?
So what we've looked across is to say, in certain areas, based on the funding, is can we recapture care based on the rules of engagement? Can we recapture care within the area? And if so, then we're doing that. If we find that no matter how many providers and clinicians we put in that area, we're not going to be able to recapture because of the number of retirees that live in that area or the active duty, then that's when we make a decision to only have X number of providers and support staff. So we right-size it basically, and then we move those clinicians to another place where we'd be able to bring in more care because that's tied to readiness and skill sustainment.
Okay, let me be sure I understand one of these other. So the Army still has this hospital as #1 on their list, but the Army wouldn't have made the final decision as to when the hospital, where the hospital should be, because it's now placed outside the FY 15-19 program objective memorandum, but that would not have been a decision any longer made by the Army itself. It would have been made by the Defense Department.
Yes, sir.
Okay, thank you. Thank you, Chairman.